next-generation sequencing for improved management of patients with drug-resistant TB. And our first speaker is Daniela.
Okay, thank you, Katarina. And my talk will be not really on next-generation sequencing, but on the step before next-generation sequencing. How can we interpret and grade the mutation associated with drug resistance, and how we can start using this grade on clinical practice. And let me start by acknowledging nothing is happening. What should I do? Okay, the people that in my laboratory, together with the ReSEC-TB consortium, have really dedicated at least 10 to 15 hours per day to this project for the past year or so. And this is very briefly my outline, and let's move to the global TB epidemic. I don't need to spend time because everybody knows that we are not doing well, and we in particular are not doing well with the multidrug-resistant tuberculosis, that we do not diagnose really on time, and even when we diagnose, we have problem in linking these people to treatment. And the result of this is that we have a huge burden of MDR that is transmitted in the community, and this is affecting high-burden countries, but also low-burden countries that occasionally see a cluster of MDR or XDR tuberculosis out of the blue. And do we have new tools? Yes, we do. We have new drugs. And very recently, the WHO have endorsed the shorter MTBDR regimen with very clear recommendation for triaging people into the shorter regimen and in the individualized conventional MDR TB regimen. But we also have the WHO moving very fast in providing an update on the guidelines for the use of the new drugs that are the lamanid, that is really not very much taken up, and this is very unfortunately, and bedaquiline, that instead is flying, not as much as we would like to see, but still is flying. But in order to do that and to really treat the people in short time and with the appropriate regimen to stop the epidemics, what do we need to do? We need to triage the patients in the most appropriate way. And also, we need to push this triage as close to the patient as possible in order to allow the fastest link to care. What do we have to triage patients? We have phenotypic methods that are, by definition, unsuitable for fast triaging. If you have a slow grower bacteria and then you want to use a phenotypic method for triaging the patients, the two things just don't match. You cannot do it. In addition to that, what do we have? We have that the requirement of positive culture is affected by the high rate of contamination in some places. The infrastructure is not present in many places, and we don't have the funds and the capacity to maintain the needed infrastructure for a level 3 pathogen. And then we have issues that are linked to media critical concentration, mechanism of actions that are not compatible with in vitro testing. At the end, the time to result is low, and the quality of results is also questionable. Let's move ahead. We do have whole genome sequencing that is the main promise for the future. We believe in that, or at least I believe in that. I think this technology is today the technology for surveillance, because it's the only technology that is able to look at the overall picture and of genes that are associated to resistance and give very important hint on resistance surveillance. Basically, will tell you which of the existing tests can be used in one settings and which may be of a lesser use in another setting. But we are not there. We cannot use today full genome sequencing to influence the therapy. So let's move to what we have now. We have the WHO endorsed molecular tool, the expert. We have a big promise by the expert ultra that will allow us probably to detect more cases, somehow also more MDR-TB cases, but definitely is the starting point. So it's not triaging the patients for the short regimen. We have the LPA that very recently was endorsed by the WHO as a tool that can be used for triaging the patients into the short regimen. What are the problems? We do have discrepancies, and the discrepancies are many, and those have been discussed by all of us, and we are all aware about that. The point I would like to make with some slides is that you cannot look at the discrepancies between phenotypic and genotypic as they are a problem, but we are looking at this phenomenon from a different angle. So they will never match. Somehow there is a need to complement each other, but we need to remember that molecular tests predict resistance. They do not predict sensitivity. Even when we will have an overall picture at the most complete possible, we will never be able to completely exclude sensitivity, and we will be talking about prediction of resistance. The more complete is our knowledge, the better we will do in triaging people with molecular tests in the fast way. And then let's move very shortly into a possible algorithm that pretty much summarizes what the role of the LPI for triaging people for the short regimen. What is recommended right now is that any mutation to fluoroquinolones and injectable are basically excluding people from individualized MDR treatment. And for those people, of course, we can consider the new drug. But are we sure on the existing knowledge we cannot do a little bit better? At the beginning of this year, this paper came out in the International Journal of Tuberculosis, Lung Disease, in which a group of experts, that was really expert-based, was providing suggestion for the interpretation of mutation for the clinical management of the patient. But now, going into the main topic of my presentation, what have we done so far? The RESEC-TB consortium was really started to lead this process, to gather all the possible data and generate and evaluate the new data to develop a platform that could allow us to grade the mutation in order to associate them a role for clinical interpretation of drug resistance, and so really for triaging the patients. So what has been done so far was the beginning of the process. So it was probably the biggest meta-analysis that was ever done, considering all what was up there, and we didn't want to throw away, to really categorize the mutation in order to be able to start today triaging the patients with the sample and the assays that we have today. And of course the focus was in the most known genes, the one for which we have data available. Thresholds were established, and we established the threshold used in the evidence-based medicine that were adapted to grade this mutation. Why? We established the threshold based on likelihood ratio and odds ratio because those are independent for pretest probability. So if we have a black less than 1, we have really no confidence in the association. The association, if it's there and if it's in some paper, is due to something else. Then we have the indeterminate, that is the category for which we need to build more knowledge. We don't have data to provide this association. And then we have these three colors that are the green, very high association, yellow, intermediate, but still we have confidence in the association. If it was my son, I wouldn't treat him with this drug. If it's in the red, for which we may have a problem in interpreting that, and we have to go on that. Why this work is important? Because there's a very large number of entries, and there's a global representation, more than 40 countries, and we have very high numbers for some genes and determinants. Let's go to the grading score. What comes immediately up to your eyes is that depending on the media, you change the interpretation. And you see that what is yellow here may become green over there. And definitely a lot of mutations that were well known as low confidence determinants for low-level resistance to rifampicin are becoming medium to high confidence if we are testing in solid media. We had this knowledge from some published paper. We also had some feeling. We also had some rumors, but those are real data that are associating the color and the grading to a specific mutation. And then we do also have the knowledge that is needed to interpret some of the discrepancies between the expert results and the phenotypic testing. Expert may pick up, or other molecular tests may pick up synonym mutation in the hotspot. Then they can provide a result that then need to be, can be misleading for the patients. Let's move to fluoroquinolones. That is a very huge mess right now. Let me call it in this way. Why? Because this is a key drug. This is moxifloxacin is a key drug for the short regimen, but is also very important for the long regimen. So dropping out moxifloxacin is a major problem for the treatment of the patient. And what we see here, we see again that we have some discrepancies between liquid and solid that you can see here for moxi. And this is due to the fact that mutations that are associated to moxifloxacin resistance, such as the A90V, is not associated in liquid. It seems associated in solid, but the MIC is different, and we can overcome maybe this the value, the plasmatic value, and